It's a 30-minute mistake series. Have you heard the murmur? Can you tell me the name of this murmur? Okay, I'll tell this murmur at last. Okay, starts with my new series, Cardiology Mistake Series Part 2. Uh, with the timer of 30 minutes, start with this question. Okay, now this 35-year-old man, 6 months history of intermittent chest pain. He's on as he's asthmatic, so he's on inhaled corticosteroid beta agonist. And there is S for gallop. This is a very high yield. There is S for gallop. ECG shows left ventricular hypertrophy. 35-year-old left ventricular hypertrophy. Echo shows left ventricular hypertrophy with asymmetry. ECG show left ventricular hypertrophy with asymmetric septal hypertrophy. So S for gallop, ECG show asymmetric left ventricular hypertrophy. What should be its most appropriate therapy? Okay, looks like it is HOCM, hypertrophic obstructive cardiomyopathy. Why? According to ECG and echo findings, looks like this. Okay, I'm going. And we know that in HCM we use beta blocker and non-dihydropyridine calcium channel blocker. That means verapamil or diltiazem can be used. And evidence of dehydration and vasodilator. Evidence of dehydration and vasodilator. Avoid decreased left ventricular volume. ICD placement for increase sudden cardiac death. Septal ablation and cardiac placement. Transplant should be done. So in here, what we are going in here, there is S4 or audible S4, and there is ECG shows left axis deviation. There is abnormality in the depolarization. There are like Q waves, and there is echo is a very high septal left ventricular hypertrophy and dynamic left ventricular outflow tract obstruction and left atrial dilatation. So left atrial dilatation, septal left ventricular hypertrophy and dynamic left ventricular outflow tract obstruction. So these patients are exertional symptom dyspnea and echography revealing left ventricular hypertrophy. Looks like HOCM. There is S4. There is S4. Um, there is dynamic left ventricular outflow tract obstruction. There is dynamic left ventricular outflow tract obstruction. So in HCM, negative chronotropy and negative inotropic drug should be given. So we actually use beta blocker, which is a first line therapy metoprolol in patients with HCM and contraindication to the beta blocker, as he is asthmatic, very high health word. Beta blocker. Why we are not giving beta blocker? Why we are not using beta blocker? I have done a gross mistake. Like I have given a drug like a lisinopril. Lisinopril is not used in here. Evidence of a vasodilator group of drugs. So these drugs, uh, AC inhibitor or calcium channel blocker, dihydropyridine calcium channel blocker, it tend to worsen the HCM, causing vasodilatation, both venules and the arterioles, So as the patient is asthmatic, beta blockers cannot be given. So we are choosing verapamil non-dihydropyridine calcium channel blockers. Okay, the next question in here. 64-year uncontrolled hypertension is brought to the emergency department. Medical therapy initiated. 6 days later, the patient develops sudden onset leg pain. So he has done PCI. Then there is sudden onset leg pain, and the pedal pulses are present on the right, but the pulses abnormally no pulselessness. Looks like acute limb ischemia. So we are doing echo. Why we are doing echo? We are doing this is acute limb ischemia. How we have diagnosed it is acute limb ischemia, leg pain, arterial occlusion, signs of cold, mortal leg, lacking pedal pulses. There is anterior segment elevation MI, his acute limb ischemia most likely given the patient's recent MI done, PCI done, so his acute limb ischemia is due to embolization of the left ventricular mural thrombus. So his acute limb ischemia is due to left ventricular mural thrombus. That's why patients with large anterostate elevated MI, patients with large anterostate elevated MI, occlusion of the occlusion of the LAD has a highest risk of having left ventricular aneurysm formation. Very very high when especially when reperfusion especially when reperfusion is unfeasible or delayed treatment initiated after 8 hours of the ischemia. When the left ventricular aneurysm forms, the left atrium aneurysm forms, the infarcted muscle fails to contract, and during systole and is associated with left ventricular ejection fraction and stasis of the adjacent blood. These may lead to a formation of the left ventricular thrombus and can embolize and causing acute limb ischemia. So as the cause of cardiac, so you should do transthoracic echo with contrast to assess the left ventricular aneurysm. We are doing the transthoracic echo. Why? To assess the left ventricular aneurysm and residual thrombus. The presence of either finding may impact the duration of the coagulation. Okay, that's it. Next, look at, just try to hear the murmur. Looks like continuous murmur. The murmur is present in throughout the cycle. This murmur is present throughout the cycle. So looks like PDA because and it is in the left sternal border. It is in the left sternal border. Just reading those things is very hard to find out the murmur. So you need to hear the murmur for finding out the murmur. Okay, okay. Other murmurs like here the murmur of the ASD, atrial septal defect. We know that the atrial septal defect, this murmur is present in the left upper sternal border. This is wide fixed splitting, mid systolic crescendo decrescendo murmur, mid systolic crescendo decrescendo murmur. And now here are the MVPs. This is the MVP late systolic murmur.
Mitral valve prolapse.
Okay. Now here the aortic stenosis. Okay, we have heard the aortic stenosis murmur. We have heard the mitral valve prolapse murmur. We have heard the ASD, which is endocardial cushion defect, are commonly associated with Downs septum primum defect, and we have heard the PDAs, very high yield. Okay, so this patient, 68-year-old man, recent coronary bypass. CABG done. CABG done. Examination show mid-sternal wound that is clean and is well approximate sutures. There is well approximated suture, minimum serous discharge at the lower edge. Looks like sternal dehiscence. After CABG, if there is clicking and shifting, this word, the clicking and shifting when he bends forward, clicking and shifting when he bends or moves his upper extremity, when he bends or moves his upper extremity, there is clicking and shifting. Examination reveals mid-sternal wound that is clean, mid-sternal wound that is clean, and a minimal serous discharge at the lower edge, but without erythema. So if you palpate the sternum, appears to be rocking and clicking with coughing. So these words, clicking, rocking, coughing, shifting, these type of words when you get. So think about sternal dehiscence and say which done. This patient has this patient presentation concerning for sternal dehiscence, a complication of the cardiac surgery, that occurs when two approximated when the two approximated edges of the bony sternum separate, typically due to a losing or fracture of the suture, where patient mild pain and the sensation of stability, clicking with chest movement. The diagnosis can be made radiographically displaced sternal wear and clinically palpable rocking or clicking of the sternum will confirm the diagnosis. This is a surgical emergency. Sternal fixation should be done to prevent cardiac damage from loose wear or bone fragments. Next, look at the ECG. Look at the ECG first. Okay, in this ECG, this is the onset of P wave, the onset of QRS, onset of P wave to onset of QRS complex. And this is um, more likely PR prolonged. So everywhere there is PR prolonged. So PR prolonged is first degree AV block. So in here you need to do observation, prolonged PR interval, first degree AV block. You need to do prolonged PR interval, P wave always followed by the QRS complex, and the third degree AV block, P wave not followed by the QRS complex. P wave followed by the QRS complex, and if the P wave not followed by the QRS complex, think about third degree block. Okay, next, look at the ECG again. Two things two things has to remember in this question. In V1, V2, V3, V4, and V4, 5, 6 lead, there is tall Q. That means he has previous MI that happened. Now there is ST elevation, tall Q. Now ST elevation in the limb leads. Think about aneurysm. Think about left ventricular aneurysm. Though I have made wrong, but I understand this. Like left ventricular aneurysm, and it happened after a month. Like he if you read this question, the patient was hospitalized 4 months ago. He has history of MI after having 2 days of chest pain. So this and that, he has having MI, and so he has a history of previous MI. But and now there is distended JVP, there is bivascular crackles, there is distended JVP, there is bivascular crackles. So looks like there are some sort of failure, there is edema too. But when you see the ECG, you find deep Q. You find deep Q in the limb lead along with ST elevation. Think about left ventricular aneurysm. So persistent ST elevation and deep Q wave, persistent ST elevation and deep Q wave. Echocardiographic show thin and dyskinetic thin and dyskinetic myocardial wall, thin and dyskinetic myocardial wall, thin and dyskinetic myocardial wall, thin and dyskinetic myocardial wall. So there is deep Q, there is deep Q, and there is ST elevation, deep Q, persistent ST elevation in the leads corresponding with previous MI, corresponding with previous MI. Okay, now VSD are mechanical complications. Okay, I will talk about this later. These So in left ventricular aneurysm, there are features of heart failure. There are features of heart failure. There are features of heart failure. Okay, next, this patient, a 16-year-old girl is brought to the clinic. This 16-year-old girl is brought to the clinic after passed out. Okay, the patient was unresponsive for an eye closed for 20 minutes. So difference between syncope and conversion disorder, you need to differentiate. Like, after the patient got unconscious in syncope, there is consciousness will regain within 1 to 2 minutes, but if he's remain unconscious for more than 5 minutes, 10 minutes, think about conversion disorder. That is a trick in this question, and I have lost. Okay, this question is very straightforward, like hypotension, tachycardia. So he has a history of motor vehicle collision. There is hypotension, tachycardia, this distended neck vein, and chest X. There is small pleural effusion, small. So looks like it's cardiac tamponade, not aortic rupture. Looks like it's cardiac tamponade. It's acute cardiac tamponade. That's why there is not a distended heart sound. Backstride is some sort of backstride follows, but aortic rupture is often immediately fatal, and in rare instances, aortic rupture with bleeding into the left pleural space, and that has been contained a hematoma and can present with left-sided pleural effusion and hypotension. But however, it can cause hypovolemic rather than obstructive with a flat with a flat rather than distended neck vein. If it is the neck vein is distended, so neck vein distension is symbolize cardiac tamponade. If the neck vein is flat, if the neck vein is flat, and after fluid given, it is neck vein is flat. After fluid given, it is corrected. So then it would be hypovolemic hypotension. So hypovolemic hypotension with a flat neck veins, think about the aortic rupture, because in aortic rupture there is loss of blood, hemorrhage, hematoma, bleeding into the left pleural space. So on that purpose, on that context, so in aortic rupture there may be hemorrhage, so flat neck vein will be distant, leg vein will be flat, neck vein will be flat, and there is hypovolemia, not like obstructive hypertension. Okay, next. This 34-year-old man, due to exertional shortness of breath over the 6 months, exertional shortness of breath over the 6 months, and the patient says his exercise capacity and has significantly decreased compared to the last year. He has chronic back pain, which responds well to ibuprofen. Chronic back pain is responds well to the ibuprofen. Mm, In here, the most important thing we need to remember this line. Physical examination show impaired spinal mobility and limited chest expansion. Impaired spinal mobility, limited chest expansion, exertional shortness of breath for 6 months, mm, and exercise and significantly decreased compared to the he has chronic back pain. If the chronic back pain more than 3 months, age less than 45, will respond to the ibuprofen and naproxen. and there is impaired spinal mobility, limited chest expansion. Think about AS, and in aortic, think about AS, that means ankylosing spondylitis. In ankylosing spondylitis, AR is the common complication happens in AS. Like in ankylosing spondylitis, there is multiple complication: osteoporosis or vertebral fracture, aortic regurgitation, osteoporosis or vertebral fracture, aortic regurgitation, and chordae icona syndrome. Osteoporosis, vertebral fracture, and chordae icona syndrome. Then the next question, so ECG in here, what I have missed, 2 by 6, 2 by 6 mid systolic murmur at the left upper sternal border. ASD is present in the left upper sternal border. ASD is present, VSD is present in the left lower sternal border. And PDA is a continuous murmur, not like mid systolic murmur. So think, so it is ASD. Pulmonary hypertension and right-sided heart failure can develop if left untreated and rarely progress to the Eisenmenger. So it rarely progress to the Eisenmenger syndrome. So look at the Eisenmenger syndrome. There is left to right shunt through the ASD, VSD, and PDA. Over time, the pulmonary vascular resistance increase, leading to bidirectional flow. Now, continued increase in the pulmonary vascular resistance. Pulmonary vascular resistance leads to shunt reversal, right to left, Eisenmenger, right to left, and Eisenmenger. Next, now 6 feet, 6.2 meter height, 20 feet, mm, uh, although he partially braced his fall, outstretched arm and legs, blood pressure is higher. Mm, this patient, the lower extremity is cool to touch and diminished femoral pulse bilateral. Lower extremity is cool touch and diminished femoral pulse bilaterally. There is superficial abrasion on the palms and the knees. So uh, he fall from 20 feet height, 6 meter height. He fall from 6 meter height. BP is higher. People look symmetric. Breath sounds are symmetric. Patient's BP high is not BP high, not hemodynamic unstable. So blunt thoracic injury, blunt thoracic injury. This is blunt thoracic injury. Uh, Blunt thoracic injury. There is tear in the incomplete rupture is tear in the intima, tear in the intima and medium, and there is pseudo coarctation. So this patient has blunt chest trauma, sternal bruising, sternal bruising. In here they have told you about the sternal bruising, the superficial abrasion. So there is sternal bruising following rapid deceleration is at risk for blunt thoracic injury. There is rapid deceleration, exert stretching, shearing, and torsional forces. Shearing, stretching, shearing, and torsional forces capable of rupturing the aorta. Capable of rupturing the aorta. The aortic stem is the transition zone between the relatively mobile or ascending aorta or arch and the fixed descending aorta, and is particularly vulnerable to these forces and the most common sign of blunt thoracic aortic injury. Common aortic rupture, tear in the intima, media, and adventitia typically results in rapid exsanguination and death. Rapid exsanguination and the death. The patient who survived the fall likely has an incomplete rupture tear of the intima or media, which may result in creation of the secondary false lumen, creation of the obstructive intimal phlegm, pseudocoarctation, proximal hypertension, upper extremity, and diminished femoral pulses. Okay, so this patient elevated blood pressure. There is nasal bleeding. So nasal bleeding, elevated blood pressure. If you find elevated blood pressure, nasal bleeding, find tremor, BP higher, looks like cocaine. So he is on cocaine. That's why there is nasal perforation, nasal bleeding, hypertension, nasal perforation, nasal bleeding. Think about cocaine. Okay, next this patient neck veins are flat. Neck veins are flat, not distended, not cardiac tamponade. He received 1000 ml normal saline and symptomatic movement. So think about the hypovolemic. Uh, he received symptomatic improvement. Her blood pressure 96, 90 by 60. It repeat ECG unchanged from the initial ECG. So initial workup has done catheterization, 70% LED, these and that, 90% proximal LED, and 80% coronary artery. 5 hours after the catheterization. What happens 5 hours after the catheterization? His BP falls. Looks like there is volume loss. Mm, and after giving volume, there are some symptomatic improvement, but ECG is unchanged. Think about retroperitoneal. That means he has some sort of bleeding. Bleeding happened in somewhere. We haven't found the area. The patient presentation: recent cardiac catheterization, anticoagulation with a heparin, sudden onset hypotension, tachycardia, flat neck veins and pains, back pain. Is consistent with retroperitoneal hematoma due to bleeding from the arterial excess side, due to bleeding from the arterial excess side. Local vascular complications of the catheter side bleeding, hematoma, arterial dissection. Most hemorrhage or hematoma formation occurs within 12 hours of the catheterization. If the patient is hemodynamically stable, if the patient is diagnosis is confirmed by CT scan of the abdomen and the pelvis. Uh, Treatment is supportive with intensive monitoring. Surgical repair of the hematoma or retroperitoneal hemorrhage is rarely needed. So it is a rare condition, rarely needed. So we need to find out the hematoma. We need to give the fluid. If blood is needed, we need to give the, and we need to do a CT scan of the abdomen to find out the retroperitoneal hematoma. This patient ST segment elevation 2-3 AVF. So it looks like it's right ventricular MI, right ventricular MI. In right ventricular MI, what will happen? Right-sided preload will be increased, but left-sided preload will be decreased. Systemic vascular resistance will be increased. In right ventricular MI, right heart failure, right-sided preload is increased, left-sided preload is decreased, cardiac output is decreased, systemic vascular resistance is increased. Okay, next, this this is a very tricky question. Uh, Leaning forward in chair relieves pain somewhat. So think about, and there is ECG, ST segment elevation in all limbs and precordial. This is the pericarditis ECG. So ST segment elevation in all limb and precordial leads, and all limb and precordial leads except V1 and AVR demonstrate ST segment depression. Demonstrate ST segment depression. So this is post cardiac injury syndrome. Post cardiac injury syndrome. So this patient's chest pain and ECG finding diffuse ST segment elevation with reciprocal ST depression V1 and AVR are consistent with acute pericarditis given his recent MI. Given his recent MI and he most likely post cardiac injury syndrome. A pericarditis that can occur several weeks to months after cardiac injury. Several weeks to months after cardiac injury. When post-cardiac injury syndrome occurs uh, following MI, especially it can refer as. So this one is very high L word. When post-cardiac injury syndrome occurs following MI, so post-cardiac injury syndrome following MI, post-cardiac injury syndrome following MI, it is Dressler syndrome. So this patient's chest pain and ECG finding diffuse ST segment elevation and reciprocal ST depression in V1 and AV are consistent with acute pericarditis. Given his recent MI and he most likely post cardiac injury syndrome. So post-cardiac injury syndrome occurs following MI, referred as Dressler syndrome. Dressler syndrome. So choking bedside. Okay, we know that high output cardiac failure due to hyperthyroidism or AV fistula. There is no hyperthyroidism or AV fistula. He has just atrial fibrillation. Echocardiography normal side left ventricle with hypertrophy, left ventricular ejection fraction is 55, looks like normal left ventricle, but the BP is higher. Mm, So this patient comes to palpitation, progressive shortness of breath over past few weeks, choking sensation, cough over time, and BP is higher. So looks like heart failure with preserved ejection fraction. So this patient has heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction, which is a diastolic dysfunction. Heart failure with the left ventricular ejection, left ventricular diastolic dysfunction due to impaired relaxation. Left ventricular diastolic dysfunction due to impaired relaxation. Left ventricular due to impaired relaxation. Okay, next. So we can slowly rising carotid pulse. If we look at this patient, this 67-year-old patient 67-year-old patient and other clues. He has he reports that having a similar episodes, having a similar of month while carrying when he take a heavy bag, heavy things. So he lose consciousness. So syncope. So syncope has a broad differential diagnosis from beginning to life-threatening condition. Exertional syncope usually portends underlying pathologic cause including ventricular arrhythmia. These patients presentation of progressive dyspnea, exertion fatigue, exertional syncope suggestive of outflow tract obstruction. Patients with fixed outflow tract obstruction, severe AS. Severe AS cannot increase cardiac output in response to exercise induced vasodilation leading to hypotension and transient cerebral perfusion. Patients with finding severe AS include pulsus parvus and tardus, delayed and diminished pulse, presence of single soft second heart sound, mild uh, mid to late peaking systolic murmur, maximal intensity at the second right intercostal space radiating to the carotid. Okay, next. So this patient S3 new holosystolic murmur at the apex. So do an echo. Why? Pericardium cardiomyopathy, 38 weeks of gestation problems. After 38 week gestation problems in the breath, there is presence of S3. So presence of S3, ejection fraction is low. Low ejection fraction, there is presence of S3, looks like peripartum cardiomyopathy. S3 suggestive for decompensated heart failure due to peripartum cardiomyopathy. Peripartum cardiomyopathy often causes secondary MR. That's it. Okay, just hear this media. So looks like bounding pulse and AR. This is an AR. This is the sound of an AR. Decrescendo diastolic murmur. Here again. Diastolic decrescendo murmur. Mitral and tricuspid both valve closure. So this is the AR murmur. Now listen to this murmur. This is the aortic stenosis murmur. Okay, so we have heard the AR murmur, we have heard the aortic stenosis murmur. Last question. Last question of this cardiology you world mistakes series. Okay, this one is very confusing. This 56-year-old man during emergency department exertional angina, this and that. ECG shows sinus tachycardia, 2 mm ST segment elevation in V1 to V4. What is the most likely diagnosis? Okay, so 90% stenosis, he is on drug-eluting stent he is given, and the post-procedural course was uncomplicated. Echocardiogram was normal. Medical history. Patient is currently unemployed. So patient is unemployed. He has got drug-eluting stent. We know that when any patient got drug-eluting stent, he should have to get dual antiplatelet therapy at least 12 months, 6 to 12 months. If he's as he is unemployed, he has not the ability of buying the dual antiplatelet therapy. So ECG shows sinus tachycardia with ST segment elevation in V1 to V4. That means medication non-adherence is the cause of this thing to happen. Okay, this is a very classic series. And finally, first murmur, what you have heard, that one is aortic regurgitation. Okay, goodbye. Have a nice life.